Next up is assessment, and this is the procedures by which the counselor or the program evaluates and identifies the strengths, weaknesses, problems and needs for the development of the treatment plan. Okay, in assessment, the global criteria is that first of all we want to gather the relevant history from the client, and that is including but not limited to their substance abuse, and we do this using the appropriate interviewing and counseling techniques. Next, we want to identify methods and procedures for obtaining any corroborative information that we need from significant secondary sources regarding the client's alcohol and other drug abuse, but also their psychosocial history. Next, we need to identify the appropriate assessment tools that we're going to use, and then we also need to explain to the client the rationale behind these assessment techniques in order to facilitate their understanding. And lastly, to develop a diagnostic evaluation of the client's substance abuse and any coexisting conditions based on the results of all assessments, in order to then provide an integrated approach to treatment planning based on the client's presenting strengths and weaknesses and identified problems and needs. Okay, so what ICNRC goes on to say about assessment is that although it is a continuous process and can sometimes change and have to adapt to suit the client's needs, it is usually emphasized in early treatment as it helps us to create the basis of our treatment plan. And it will result from a combination of focused interviews, tests and record reviews. And what we're really going to be assessing is the key areas of the client's life that are affected by their addiction. Some of those being physical health, psychological functioning, as well as social adaptation, so biopsychosocial, and some additional areas being legal involvement as well as vocational development. And in some modalities we would also explore spiritual development. Now, by assessing how these areas are affected by the client's addiction, we can then start to formulate our focus for treatment and the treatment plan. So just briefly, when and how assessment takes place, as we've already said, although it's emphasized in early treatment, it is an ongoing process. And that's just quite simply because the client's not going to be facing the same problems and situations and have the same needs throughout their recovery as time goes on. So as situations change, so too will your focus of treatment. Secondly, it results from a synthesis of information, so collective information coming from records, interviews, and testing. And lastly, it is necessary to use a multidisciplinary approach. And so the most effective treatment will come from a multidisciplinary team so that you can cover all of those areas that we mentioned before, and we're going to look at in goals of assessments in more detail and gain a broader spectrum of information to formulate your treatment plan. Okay, in goals of assessment, the first thing we want to do is determine whether the client actually has an addiction problem or whether it's a substance abuse or substance dependence problem. We'll look at the criteria of those three more in the addictions theory course module. But secondly, to identify any addiction related problems in the following areas. As we said, it needs to be a multidisciplinary approach. We want to accumulate as much of a broad spectrum of information as we can. So we will explore these areas being psychological, physiological, behavioral, family, economic, environmental, interpersonal, spiritual, as well as other drug use or multiple addictions. And in that we include behavioral and process addictions. Because what you find in many cases is that if somebody suffers from chemical addiction, there's usually an accompanying manifestation in a behavioral or process addiction. For example, sex addiction or shopping addiction or even eating disorders. Next, we want to increase the client's likelihood of entering and remaining in the treatment program. And we do this by identifying barriers to treatment, so any possible excuses they have for avoiding coming into treatment or staying in treatment. We want to evaluate the validity of any of these excuses, and possible solutions to them if they are valid. So for example, if they're worried about certain bills getting paid or somebody looking after their animals, or any of these kind of responsibilities, if we can explore other solutions and ways of dealing with those so that the client can stay. We also want to reduce the client's anxiety about treatment and dispel any preconceived ideas they might have about what treatment is. Lastly, we need to satisfy the demands of insurance companies, and in our country that's medical aids, for determining diagnosis and prognosis, as usually, not all, but some medical aids will require a DSM form, for example, to be filled out and sent to them to give them that kind of relevant information. Next is treatment planning. And in treatment planning, the client and the counselor are going to identify and rank the problems that are going to need resolution. They're then going to establish the immediate, short, and long-term goals, as well as decide upon the treatment process and resources necessary that they want to utilize. Okay, the global criteria for treatment planning is, first of all, we want to explain the assessment results to the client in an understandable manner. Then, as we said before, we're going to identify and rank the problems needing resolution, and that is as based on the individual client's needs, and we want to do this in a written treatment plan. Then we're going to formulate agreed upon immediate, short, and long-term goals. And we want to do this in behavioral terms, and what we mean by that is using words to describe behavior, and we're also going to put that into the written treatment plan. And then lastly, we want to identify the treatment methods and resources that we're going to utilize as appropriate for the individual client. Okay, so the treatment plan is pretty much based on the findings of your assessment. But it is also an ongoing process, so as much as assessment is ongoing and can change, so too can your treatment plan, depending on what your client's particular needs are at any given stage and what changes may occur. But it has to be agreed upon, and so the first thing you're going to do is sit down. It's a negotiation process between the client and the counselor to determine what the goals and strategies and objectives are going to be. And once that's agreed upon, you're going to sit down and put that in a written format or treatment plan that should then be signed by the client and the counselor. Now, the language that you use to describe these problems, goals, strategies, and objectives needs to be very specific and kept simple, and it needs to be expressed, as we said before, in behavioral terms. Now, the goal statements are referring pretty much to an objective or a set of objectives that are ultimately intended to then solve or mitigate the problem. Now, these goal statements are described or expressed in behavioral terms so that the counselor then can track the progress of the client throughout their treatment. Now, the plan or strategy is going to describe what services the client is going to need, who's going to provide those services, when they're going to provide them, and at what frequency. And then lastly, we also need to remember that the treatment plan is a dynamic process, as I mentioned before. So that means that it needs to constantly be reviewed, and it can be updated or changed if necessary, as long as it's agreed upon by the client and the counselor. We're going to run through the tasks of treatment planning, and there's quite a few, so I'm going to refer to my list here in front of me, which is the same list you have in your manual. Just as a side note, there is a sample treatment plan at the back of your manual, as well as on a link on your course page. It is the ASI treatment plan, which is the Addiction Severity Index version, and it should give you a good idea of what a treatment plan looks like and the kind of information you want to have. You could use that document, or you could adapt some of its information to suit your own particular treatment program. So the first thing, as we've said before, is that the basis of the client's treatment plan is going to be the assessment. And it says here that the Commission on Accreditation of Healthcare Organizations requires that the treatment plan be based on the information that you get from the intake as well as assessment. Remembering that your intake is going to have all of your screening information and documentation as well. So that's all your eligibility criteria and your diagnostic criteria and so on. But then they're saying here that the plan, based on the presenting problems, behavioral, physical, and emotional, should be developed within the first 72 hours of intake. Now, that's not always possible. It depends really on the condition of your client. If you're in a treatment center, your client might be going through a detox or withdrawal, in which case they're not going to be physically or mentally capable of doing much of this. So you would wait until they are. Next, the treatment plan should be individualized, so it's going to be based on the client's individual needs, as each client has different needs, and they should identify their strengths and limitations. And then they're saying here that you should involve the family where appropriate. Now, I don't suggest you involve the family in the early stages, as you're still trying to establish trust and rapport with the client. So you want to keep the family out of it for now. You're dealing with the more severe problems, which is their withdrawal, detox, and their addiction. And at a later stage, you can start to move onwards into family issues. And at that point, you'll start bringing them in. But what you can do in the meantime is quite useful, is confidentially get the family to fill out some questionnaires or some information of their insights, or not their insights, but their experience of the client, being the parents or the siblings or significant other, which can just give you some useful and valuable information about the client before you actually start the whole process. You would obviously never share that with the client unless absolutely necessary, and only with consent from the family member who provided the information. Alright, next it says to create a treatment plan, the client and primary counselor must list the significant problems, and then we're going to rank them in order of priority. So we're going to deal with the most important or critical issues first, and then we're going to start to move on to the outer and peripheral issues and challenges that they're facing. So examples they've given 9 here is firstly their alcohol dependence, then their other drug dependence, then withdrawal history and concerns, unemployment, sexual abuse, marital difficulties, adult child of alcoholic parent or parents, lacking drug-free peer group on the outside, and then recent death of a significant other. Now, ranking it in priority, you could see that the first 3 are obviously the most important, because until they've actually dealt with their dependence as well as their withdrawal and detox, they're not really going to be capable of dealing with any of the other issues. So you're first going to deal with their treatment program, working on those areas, and then at a later stage you can start to explore things like vocation or unemployment and marital difficulties or family counseling and so on. Now, once the problems are identified, the client and the counselor then negotiate long-term and short-term goals. And as we said before, they need to be agreed upon. And some examples they're giving us here. So a long-term goal being Mary Smith will remain alcohol and drug-free with the help of an ongoing support group. So that's the long-term goal. Now, the short-term goal will be the objectives that she needs to complete in order to reach that long-term goal. So they're saying she will remain in a weekly individual counseling session. She will attend AA meetings 4 times weekly. She will begin to utilize the AA tools, slogans, sponsor, phone numbers, and so on. In the second example, they've got Mary Smith will develop vocational skills that will enable her to maintain consistent employment. So that long-term goal. In order to achieve that, she's going to make an appointment with the Department of Vocational Rehabilitation within the next 2 weeks. So there's an objective in order to complete the long-term goal. Right, moving on, it says goals should be expressed clearly and in concrete, measurable behavioral terms, and should include expected date of achievement. Okay, so we want to have deadlines. It's a good thing to have deadlines, because this, first of all, motivates the client a little more to achieve these objectives, and secondly, creates an atmosphere of accountability. Now, there are guidelines, so we don't need to be strict or rigid with this, but we should have them in place. And then specific counseling strategies and services should be identified, as well as who will perform these tasks, where they will take place, and how often. Outside referrals may be considered, and we'll discuss that a bit more in the referral section of the 12 core functions later on. But that's basically if we need doctors, legal advice, vocational advice, and so on. Client progress notes should regularly reflect attention to the specific areas that we've pointed out in the treatment plan, and documentation of progress and struggles in these specific areas should be noted. It's very important. We're going to cover this in reports and record keeping, but it's very important to keep notes on everything that's going on for the clients for your own reference, as it's hard to keep track over a long period of time of everything that's happened. So we need to be able to identify patterns of behavior and of problems that the clients have, and we can only do this if we constantly record what's happening. Okay, a resolution of problem areas specified in the treatment plan should be documented in the progress notes and or the treatment plan itself. And then the treatment plans should be reviewed regularly. Okay, it's saying here every 7 to 10 days by the client and counselor and by the clinical supervisor and or treatment team. So a general rule of thumb is to do a weekly progress report and to look over that weekly and then share that information with the clinical supervisor for any additional consultation. And what most treatment centers do is they have a daily meeting where they also discuss the progress of their clients. We'll also cover consultation a bit later. Right, treatment plans should be reviewed. Oh, sorry, I said that. Treatment plans should always allow for flexibility and changes in addressing client problems, needs, and goals. And as we kind of said right in the beginning, the client has no idea, and you have no idea what other problems might occur throughout the treatment process. So we always need to remain flexible, and that's why assessment is ongoing and why the treatment plan is dynamic and can be changed and updated regularly to suit the client's needs.